Hi, I'm Kristen with UT Southwestern Medical Center. Today we're excited to be chatting with electrophysiologist and cardiologist Dr. Richard Wu. Dr. Wu is a nationally recognized specialist in evaluating and treating cardiac arrhythmias and has been at the forefront of using cardiac ablation procedures to treat these conditions for 20 years now, or close to 20 years. So we're really excited to have Dr. Wu with us. As usual, we can't comment on really specific patient-ish questions due to patient privacy laws, but we can talk in general about it, and we will for the next 25 to 30 minutes. If you haven't already submitted a question in advance, now's a great time to add those questions in the comments stream on your Facebook feed. So we're going to go ahead and get started. Thank you for joining us, Dr. Wu.
Thank you for the invitation. I'm excited to be here.
Absolutely. So it seems like Afib is becoming something that's more common. What causes atrial fibrillation?
Atrial fibrillation is, as you mentioned, a very common arrhythmia. It affects about over 1 million people, but almost 1% of the adult population. So it occurs as with age. So you tend to see it above the age of 55 in most patients, and often there's some association with other comorbidities or coexisting conditions such as high blood pressure, diabetes, and sleep apnea. It's something more increasingly recognized.
Gotcha.
So
Okay.
lung and heart and lung disease.
So we've got quite a few questions that came in advance, including one here from Jay. And his question is, do stents pose any problem with ablation?
For the ablation procedure, we don't go near the stents. I'm assuming the coronary stents. The main issue is that the patients have to be on blood thinners, and sometimes they're on the blood thinners along with aspirin or Plavix. These are antiplatelet drugs, so there's a higher risk for bleeding. So we do have to kind of make some arrangements around that. And if the stent is recently placed, we have to wait usually for anywhere between 1 to 3 months before doing it, so we don't risk bleeding or clotting complications.
Okay. You mentioned when you started the answer that atrial fibrillation is common. Can you give us any statistics on how common it is?
It's estimated at least 1% of the adult population. So in the U.S., you're talking about maybe between 2 to 3 million people. Sometimes it's experienced only once in a lifetime, but for others, it's a more chronic condition. And the prevalence is going to increase with age. So it's probably about 3 to 5% of the age group above the age of 70.
Okay. All right.
So much more common in
Gotcha.
elderly patients.
Okay, good question. So we have one here from Kristen, and given that her question is, what are the complications associated with Afib, and are they related to age as well?
Right. So it is related with age. So the one that's probably the most feared is stroke. So one of the risk factors for stroke with atrial fibrillation is age. And there have been a lot of studies starting out with the Medicare population. So as you guess, that's age 65. So you do see higher stroke rates as patients get older, and it is a more linear relationship. So when you get towards 80, you have a higher risk than someone who's, say, 65. The other complications are if patients are stuck out of rhythm with a fast heart rate for weeks or months, they can develop heart failure. So there's coexistence of heart failure with atrial fibrillation in about 50% of the patients diagnosed. So it can worsen heart failure, or a lot of times the atrial fibrillation is diagnosed at the same time as heart failure.
Okay, so that's really helpful. So we have a question here from Crystal. When you're talking about atrial fibrillation, are there different levels, different severity that people should be concerned about?
So there are different classifications for it. There's, you could say, initial first episode. Sometimes it's only after surgery, so sometimes called post-operative atrial fibrillation. Oftentimes that's just one event or one occurrence. But when it becomes recurrent, then there are forms what we call paroxysmal, where patients spontaneously go in and out of rhythm. Persistent is when patients get stuck out of rhythm and they stay out of rhythm for at least a week or until they are converted back to a normal rhythm, either with a drug or a shock. And then there's a permanent or chronic atrial fibrillation, where patients just stay out of rhythm continuously, and sometimes it's defined as over a year, or if there's no attempts to get patients back into rhythm.
Okay, good to know, good question. So we've got a couple questions coming in about treatments, including one from Chris, but I want to make sure we get to this question from Aji, and before we get there, and that is, what impact does a high potassium level have on the heart?
Well, if it's still in a normal range, it doesn't have a lot of impact. Usually you see more arrhythmias when the potassium level runs too low, and that's what we usually see in patients with on diuretics. So the heart does get more irritable when the potassium runs low. So the reverse is, if the potassium runs too high, like we see with dialysis patients, sometimes they will actually lose contractility. Some people can actually get paralyzed if it's too high, but that's pretty rare to see.
Okay, so going from there, what are the treatment options for atrial fibrillation at this point?
So we basically try to address at least three issues with atrial fibrillation. One is we want to control the heart rate. So we like to see it within a certain range, so roughly between 50 to 110 beats per minute. We call that rate control. For those patients who are at higher risk for stroke, we evaluate each patient to determine their individual risk factor. So we have to decide if they need to be on blood thinners to prevent a clot, which can form the heart when you go out of rhythm. The best known system for trying to estimate someone's risk is called the CHAD score, or CHAD-VAS score, and that's an acronym. C stands for congestive heart failure, H, hypertension, age, so age over 65 or 75, D is diabetes, and S is stroke, prior stroke or TIA, and sometimes we also add this VAS score, which means history of vascular disease and gender. But if you have, for example, a low CHAD score, if your age, say 50, and no other risk factors, the risk of stroke may be 0.5% per year, but roughly for each risk factor you get almost like 1% chance per year of stroke. So usually when there's more than 2 or 3 risk factors, we start to recommend use of the blood thinners. And then the other issue is symptoms. Some people can tell when they're out of rhythm, others can't. So if the heart rate's too slow, some patients may need pacemakers. If it's fast, or even not fast, but some people just feel more symptomatic, we sometimes have to decide if they need the trial of drugs, antiarrhythmic drugs, cardioversion, or ablation. We haven't talked about cardioversion, but most patients, if they're stuck out of rhythm for more than 24 or 48 hours, we usually try at least once to get the patient back into rhythm with a shock that's applied to the chest to reset the heart rate while they're sedated or use a drug. Okay.
So one of our next questions related to that, and this question is from Veronica, and about, you mentioned ablation, and her question is that her husband had an ablation a few years ago. What are risks of repeat once somebody has had that once?
Yeah, so the risks don't necessarily increase with another attempt. So ablation itself has success rates somewhere around 60 to 80%, depending on the form of atrial fibrillation. But it's well known that some patients will kind of relapse or start to have recurrences. So there may be as high as a 50% chance recurrence after about 5 years after the ablation. But it depends on the form of the arrhythmias and the way the ablation was done, but it's not uncommon for between a third to half the patients who've gone through one procedure to require another one.
Okay. So we've got a follow-up question related to ablation, and this one came in from Chris. And so the question is, can atrial ablation be performed via a route, other than the groin? And are there additional risks involved in using a different route?
Well, the main route is with catheter ablation is through the legs. If you're talking about other routes, the original way it was done was surgically, so open chest. So that's much more invasive, but that's the original form of arrhythmia surgeries through open chest.
So do they pose additional risks?
Yeah, so open chest surgery has higher risk, so I think there's more risk for bleeding and infection and clotting. So in general, if you do a surgical procedure, you're going to have a higher risk than the catheter ablation. But I think the risks are somewhat low now, and we can get into that details later.
Okay, good question. So here's one we have from Jared, and this was something that I was interested in as well. And the question is, does atrial fibrillation run in families? So is there a genetic component?
It's thought that there are some genetic components to it. It's not like it's inherited in a dominant fashion, so you don't necessarily see someone get it like at an early age and they're, like say, born with it, for example. But there are some genetic components to it, but it's not completely understood what they are. But they tend to be these ion channels, or some of these cardiac structural proteins, but it's not a pure type of disease.
It's not. There's not a definite genetic. Like if this person has it, you're going to have it.
Right.
Okay. Interesting. Very good question. Thanks for sharing. Here's another one that was intriguing to me that came in from Crystal. And since you deal with electrophysiology, Apple Watches now detect heart problems, or they can.
Right.
She's wondering, should the alerts from Apple Watches be used as a new tool for monitoring?
Right. So the issue with that is that there's some false detections and misdetections as well. So I think it's better than nothing. And we're still learning about the way to best use the technology, but it can help you decide or seek attention if you find irregularities. I'm not as familiar with this new watch that just came out that can actually record the ECGs, but I think we're just going to see more and more of that as technology gets better.
Okay, good to know. I know it seems like every week there's a new phone that says I can detect this and I can detect that. All right, so we've got a question here, and thank you for all these great questions. Keep them coming. We're about halfway done, so if you have a question, now's a great time to ask it. Here is one that's from Lori, and Lori asks, do patients with Afib or atrial fibrillation, do they qualify for a heart transplant if needed? They can qualify, but it's not based on the arrhythmia alone. So the indications for heart transplant are really for heart failure. And as we said, a lot of patients with heart failure have atrial fibrillation. So they may have it, but that's not a reason alone for heart transplant. Okay. So that's a good question. Here's one from Andy. We're getting a lot of questions today. This is great. So we have one from Andy, and her question is about if somebody's been diagnosed with atrial fibrillation, how does their lifestyle change or need to change?
Right, so there are different causes of atrial fibrillation. So there are some reversible causes, like with sometimes alcohol use or caffeine. So those are some lifestyle changes that are sometimes necessary. We didn't discuss this earlier, but some patients are diagnosed with atrial fibrillation after consuming a lot of alcohol. That's sometimes called holiday heart syndrome. So if it's due to that, for example, they really need to cut back on drinking the alcohol, and sometimes that takes care of it.
Right.
For others, there's some studies showing that if you're overweight or have diabetes or even have gone through ablation, if you lose some weight, and sometimes it's said about 10% body weight, you may reduce the likelihood of having recurrences, or we said sometimes you just have one episode, and if you make lifestyle changes, you may not have as many or recurrent episodes.
Okay, so good question, Andy. So it sounds like it depends.
It depends, right. So sometimes you can change it, sometimes you can't.
Right. So here's a question related. I mean, this is from Kristen, and she asks, can you prevent atrial fibrillation?
Similarly, it can be prevented if you have a healthy lifestyle. So there are studies showing that if you exercise on a regular basis and have a more normal body weight, for example, you're less likely to develop atrial fibrillation, although it's sometimes not always completely avoidable. The other extreme is you do see more arrhythmias in endurance athletes. So marathon runners and triathletes, Nordic skiers, they kind of push their hearts to the limit beyond what's considered normal, and you do see a higher incidence of atrial fibrillation. So you can go in both ways, being too sedentary or being too extreme.
Well, that brings up another question that came up in advance, and I'm not sure if this person is watching, but the question was, should individuals who've been diagnosed with atrial fibrillation, should they participate in physical activities, and if so, then how much?
We do try to encourage physical activity, and it can both reduce the number of episodes, and sometimes it helps the body auto-regulate the heart rate. So we try to counsel our patients to continue exercise, and in fact try to do some interval training where they try to intentionally get their heart rate up with aerobic exercise. Let it go through a more intense workout for 3 to 5 minutes. Let the heart rate slow down for 3 minutes, then repeat it for up to 4 times over half an hour. So sometimes that's called the 4x4 interval training. So you go hard 4 minutes, cool down 3 minutes, go hard again, total 4 times. So that's like a 30-minute workout.
Wow.
It's been shown to reduce the number of episodes or symptoms in patients with atrial fibrillation.
Okay, really good question. So related to that, can you describe, for those of people that, I know we have quite a few people on here that maybe have been diagnosed with atrial fibrillation, but for those who are just learning about it, what are some symptoms they should look out for? What does it feel like?
Right, so the symptoms can vary. Some people can't tell at all, so sometimes it's only detected, maybe 1 out of 10, 1 out of 5 individuals only gets it detected when they go into the doctor's office. But once you know that you have it, you probably want to check your pulse rate from time to time, particularly when you're first diagnosed, to make sure it's not too fast. Most patients that, when they're first diagnosed, I recommend getting a monitor, and as we're adjusting the medications, we like to try to get them in that nice sweet spot zone, which is between 60 to 100
So a blood pressure monitor that you would just put on your arm, or some other type of monitor?
Right. So, like as we mentioned, some of those personal monitors, these watches are not so accurate. There are some you can purchase that can measure the rhythm by applying your fingers, for example, to a metal plate.
Okay.
That can do that, and there are newer monitors coming out. But you want to check the pulse rate. So abnormal symptoms would be, of course, something extreme as fainting. That should never happen, really. Shortness of breath, and then chest pain. Normally you don't get chest pain with this unless it's very fast or you have some other coexisting problems like coronary artery disease. So then you need to get seen right away.
No, great question. And here's a question from Laura, and Laura Garza, and this is related to afterwards. So when is anticoagulation indicated for patients that undergo heart surgery and end up with atrial fibrillation?
Right, so after, this is heart surgery? After heart surgery?
Yes,
right.
That was her question.
Right, so normally after heart surgery, so that also says you have pre-existing heart disease, so you have a higher risk factor for stroke. But most patients after heart surgery will get placed on it, and there will be at least one attempt to get the patient back into a normal rhythm, like with the cardioversion, and it usually works most of the time. Then we go by those risk factors, like we mentioned earlier, that CHAD score or CHADS VAS score. So if you have more than 2 risk factors, then we usually recommend staying on anticoagulants. If it's like a younger patient, they may have had surgery for like a septal defect, and that was repaired and everything was done correctly. It may just be short-term anticoagulation and then stopping later on. But most patients, if they've had it after surgery, what I'll do is give them a monitor to hold on to between 2 to 4 weeks to make sure that there's no recurrences before completely stopping the drugs.
Okay, good. Very good question. Thank you for asking and for participating. So we talked about this earlier, but this additional person has come back, and this is Christy, about kind of the daily lifestyle changes. And her question is, how does a person's lifestyle change when diagnosed with atrial fibrillation? And it sounds like earlier you said that it really depends on the level of severity or the level of
Right, but I mean, most people will eventually get back to a normal lifestyle. Although some people, and maybe sometimes incorrectly, they stop exercising. So if you get to the point where you stop doing everything, then you're not being well managed, or you need more treatments to get things fixed. But most people are able to get back to a pretty much normal lifestyle.
Okay, so there's hope. It's
not a life sentence, or and it's something we can control.
Okay, sounds good. So we've only got about 5 minutes left, where you guys are sending in some great questions. So I'm going to go to this next one we have, and we mentioned a couple different treatment options earlier. Are there any new treatment options on the horizon that maybe aren't available yet but could be in the near future?
Well, a few things we haven't mentioned are, so it's gotten a lot better over the last, I'd say, 5 to 8 years. There have been the newer drugs, the anticoagulants. So in the past, a lot of individuals were fearful about taking warfarin or Coumadin, which is sometimes called rat poison, because that's what it's used for as well. But there are newer drugs that can be taken on a once-a-day basis and pretty much reduce the risk of stroke by about 2/3, 65%. So that's been a major change. Some people have been afraid to take that because they were afraid that there's no antidote, but drug companies have developed antidotes that act pretty quickly. One works within 10 minutes if there's a bleeding issue. There's one that just came out, but it costs $65,000, $68,000.
Wow.
Something like that to administer, so not many emergency rooms keep that, for $60,000 drugs. And then there's these new devices that are placed in the heart where the clots can form, called the left atrial appendage. So, for example, at the university, we're implanting a device called Watchman device. So it's done in patients who have risk for stroke from a clot, as well as risk of bleeding or history of bleeding. So that's a new form of treatment. Similarly, the surgeons are placing more of these devices during surgery, at time of surgery, for other conditions called the atrial clip. And that's also been shown to reduce the risk of stroke and potentially get patients off blood thinners as well. In terms of the ablation technologies, we're trying to get more specific in our targets. Right now it's done more of an anatomical approach. but particularly for patients who have recurrences, we're trying to use computer algorithms to help us localize or locate the sources for the arrhythmias and make our ablations more effective and safer at the same time.
Interesting. So it sounds like there's definitely some things happening
Yes.
on that front. So we've got a couple more questions here, and we're going to try to get to as many as we can. This first one is from Kamar, and his question is, what's the prognosis of a patient with non-obstructive hypertrophic cardiomyopathy and Afib? Is that something that we can do things about?
Yeah, so I mean, we do have a center that treats specifically hypertrophic cardiomyopathy, and having the arrhythmias does increase the risk for stroke and cardiac events, but there are treatments usually for the hypertrophic cardiomyopathy. There's a decision about defibrillators or devices that are implanted to prevent sudden death. And we can perform ablation for patients with early stages of the hypertrophic cardiomyopathy, try to help them from having so many episodes, but it's individualized.
Okay, really good question. Thanks for asking. Dr. Wu is correct. We do have a hypertrophic cardiomyopathy center here at UT Southwestern. So as we're wrapping up, I wanted to take a moment to ask you, because this did come in ahead of time. People are interested.
Okay.
How did you get interested in this field?
Right, so I was fortunate when I was in medical school, they were just developing catheter ablation at that time, and the treatment was for something called WPW, or Wolff Parkinson White syndrome.
Mm-hmm.
So I was entering my medical career at the time when they were starting to go from surgical treatment to the catheter ablation form, so that's how I became interested. And I had mentors that are also very well known in the field for doing this type of ablation or research, so that's how I got into it. And atrial fibrillation, although that wasn't my first interest, because it's so common, it becomes your main source of referrals, because it's just so common.
Mm-hmm.
So even today, I just finished a clinic, and I think 8 out of the 10 patients had atrial fibrillation. They get referred for that.
Okay. So with that in mind, what do you tell a patient that's just received a diagnosis of this? What is kind of your key messages that they should remember?
Yeah, so it's an individualized approach to treatment for each patient. So it's a common disease, but not everyone has the same symptoms or the same problems. So you have to get a detailed history and background behind it, and get an evaluation to figure out if it's something that's going to be a recurrent problem versus something that's more reversible, and then go about the treatment options based on either the patient's symptoms or how fast the heart rate is, or how common or how frequently the arrhythmia occurs. So it's just like any other kind of condition. There's no one treatment that fixes everyone, but it has to be tailored or individualized for each person.
But there are treatment options available.
Definitely treatment options, and it's sometimes confusing because there's so many treatment options, but you have to figure out what's best for each individual.
Okay. Sounds great. We are out of time. We are all done for the day. I want to thank everybody for the questions and Dr. Wu for joining us. Just so everybody remembers, this chat will be available here on this Facebook page, and we'll also post it on our YouTube channel later this afternoon. So if you have friends that aren't on Facebook that couldn't watch during the chat, please encourage them to come back and watch later, either on YouTube or Facebook, whatever their preference is. And in the meantime, thank you for answering all these questions, Dr. Wu.
Thank you for the invitation.
It's been a great day, and we'll see you next week for our next chat. Have a wonderful day.